So the FAITH project, what it's about, it's a federated artificial intelligence solution for monitoring mental health status after cancer treatment. So the important words really for us are federated artificial intelligence after cancer treatment and monitoring mental health. So, just a second, I think you covered up here. Cancer patients face several challenges which affect their mental health. This then leads to anxiety, it leads to depression, and it worsens the quality of life. So there's an incidence of 18 million new cases of cancer per year, and then this affects depression. Then will affect 15 to 25% of these cancer patients. As the population of the world is increasing, we're all getting older, and as medical science is improving, we're facing with a rising occurrences of cancer. So more people are surviving after cancer treatment, and this can lead to an impression of their self-perceived quality of life can be affected. They can feel feelings of anxiety, of depression once cancer treatment has completed. I guess these feelings happen during cancer treatment, and everyone thinks, okay, once the treatment is finished, everything is good, we can move on, but it's actually not the case. And this is what we're trying to look at in the FAITH project. So it's this consequence of anxiety and depression that we're addressing. So we're looking at an AI-based technology to track depression markers. What we've targeted in this project are activity, sleep, nutrition, and general outlook. We're tracking the general outlook through voice, similar to the Menhir project. We're trying to monitor these downward trajectories, looking to see when say these depression markers are starting to fall, and then ultimately inform the point of care of these declines. By doing this, we're going to help cancer survivors to improve their quality of life and get early detection on what's actually happening. So we've a strong multidisciplinary team in the consortium. We're working from 5 countries: Ireland, Portugal, Spain, Italy, and Cyprus. And we've got 3 hospitals, a number of technology providers, research centres, and SMEs. So the consortium then, ourselves, Waterford Institute of Technology, we're the project coordinator. We've the Polytechnic in Madrid, University Polytechnic Madrid, the LifeSTech team there. They're helping us with the system architecture, and they're also running the pilot trials. And you'll hear from Xenia later on in this presentation about how the trials are set up. We have Uninova from Lisbon. They're looking at the technology. They're looking at the sleep trackers in the project, and also with regards to technology transfer into business. We've 3 hospitals in the consortium. We've Champulamud Foundation in Lisbon, we've the Gregoria Marinon Hospital in Madrid, and UPMC in Watford. And what we've done in the consortium is we've got 3 pairings. So we've paired each hospital with a research centre. So UPMC is linked into Watford, Gregoria Marinon are linked into UPM, and Champulamud are linked into Uninova in Lisbon. And then we're also supported by 3 SMEs in the project. Deep Blue have played an important role in gathering the requirements and having co-creation workshops, and they're also in charge of the dissemination of the project. With Suite 5, who are developing the app, who are involved in integrating the different modules from the app, but also looking at exploitation paths from the project beyond its lifetime. And then we've TFC, who's led by Tom Flynn, and you can see the work that Tom has done. He's looking after standardization, quality management, and communication and exploitation. And as part of his role, he's brought this cluster together and is running this event. We also have an advisory board. You would have seen Jane Walsh this morning interacting with us. She's played an important role in this advisory board. We also have Federica Facciota and Mark Sujan. So we meet with them, bring a project to them, see what we're doing. They can see what we're doing and advise us on the progress we're making. So what are the main objectives we're looking to do in FAITH? We're looking to develop the FAITH app module, which, as I said, has 4 main areas: sleep, activity, nutrition, and voice. And we're tracking through the device-based behavior on our app. We also have validated questionnaires that are imported into the app, and then we also have trial follow-ups. As mentioned, we're going to have three observational trials in the three hospitals in Ireland, Portugal, and Spain, and to capture the prospective data that can help us build the predictive models. And then an important part of faith is developing the federated approach. So it's important that we keep the data at the edge and the users. So in the first version of our app, we're going to be used for collecting data so we can actually build the models. And then the second version, it will be the federated AI app where the models are moved from the cloud and moved closer to the device. So we're going to demonstrate applicability, usability, effectiveness, and value for faith concept models, techniques, and framework in a real-world situation. So developing the app, capturing the data, and then moving to build models and moving the models to the edge, and then proving this in a real-world situations. This is the real kind of crux of what we're trying to do in faith. So the faith ecosystem, we have the patient who's going to provide the input to the faith app through the data that they provide. We have a team of healthcare professionals revolving around the patient. They're going to help. First of all, we're capturing data from the hospitals themselves, but then also advising of what needs to be done when certain alarms are raised, with data scientists that are building the models and the federated learning approach to AI for gathering the data and monitoring at the edge. So faith, as I said, is relying on a federated approach. So traditionally, data would be collected and sent to the cloud. So as I said, we're collecting sleep, activity, outlook, and appetite data. This would have been sent to the cloud and analyzed in the cloud. We're trying to move away from that approach where the models are initially built in the cloud, but then they're sent back down to the devices, and the analysis can actually happen at the device. So we're keeping the data that the users have generated close to themselves, and we're not sending data around the place, which is improving their privacy. So when a negative forecast on the patient's mental health is detected, what do we do? We raise an alert and it's sent to the healthcare providers, and they then decide whether it's necessary to bring in the users themselves. There's still a possibility of contacting the users, but we're still investigating this within the Faith project. Some of the major challenges that we're facing in Faith. So first of all is identifying the right indicators. So we've targeted activity, sleep, nutrition, and outlook. And from this, we're going to build the prediction models. We're tackling privacy issues, and to address this, we're implementing the federated learning approach. And as I said, it means that the data stays on the mobile phone for the user and is not sent into the cloud, and it's just the models that are circulated between the user's device and the cloud. As mentioned this morning, a big part to play is trust, and as part of our project, we're looking at explainable AI, where when reasons or alerts are sent into the healthcare providers, there's always a reason given behind the decisions that the AI has made, and it's moving away from the black box approach. So we're supporting the clinicians as opposed to taking the place of the clinician. So when the clinicians get the data, they can revisit, see what's happening, we explain what's happening, and they can validate if the decisions that the devices or by our system are true or make corrections. Also engaging with users. We've had a co-creation approach at the start of the project, and this will continue through the project. Once we move to trials, we'll trial with a subset of users first and then move to larger trials so that the users are constantly engaged and feeding back to what we're doing. So the overarching goal for Faith is to build a better model for mental health monitoring, and to achieve this, we've broken it down into three smaller objectives. As I said, the first one is the federated AI solution, using prediction models at the edge. The second is the clinical validation of our tools. So through the trials, we'll be clinically validating what we've actually developed and the models, and then fostering awareness for mental health status in cancer patients and their doctors. So once the Faith concept has been prototyped, we'll go to real life solutions. When the patient is finished with their treatment, we've targeted a 5-year span. Then they can be involved in the faith trials. When they finish their treatment, then and 5 years have passed and they're getting involved, they'll get 2 devices, or they'll get at least they'll get the Faith mobile app and they'll get a tracker device. And then we're tracking the 4 markers. 2 are going to be interactive, which is the appetite and the outlook, which will be done through questionnaires and a voice analysis. And then we'll have passive collection as well through the sleep and the activity trackers. This combined with the questionnaires that we use will give us the clinical assessment of the patient. So what I'm going to do next is move over to Stefanos, who can give a talk on the device itself, and he'll walk through the use of the app. So Stefanos, I'm starting the player now.
Yes, hello. This is actually, I don't see it on my screen. I don't know why it's frozen or if it's just me. So supposedly the video is already playing.
It froze my end.
Yeah, this is a quick 5-minute video demonstration walkthrough of the mobile app as it is today with the help of a video. So we have to sync this a bit.
Can you see it now? Is it playing?
No.
Okay. Can you see the video itself? No. Stefanos,
No, we just see the...
It might work if you try sharing from yours. Hold on. Let's see. Hold on. If I can just give it a second. Start share. Okay.
Yeah, we can see it now.
Can you see now? Okay.
Yes. So let's start again the video.
Okay, I'm starting it now.
Yeah, I've seen the timer. Thanks. So this is, as we said, an effort on our side to give a 5-minute video walkthrough of the mobile app as it is today. The goal of this app is to capture, as we said, activity, sleep and nutrition data from the user. Right now, it is used in the first stage of the trials as at this role, but it aspires to evolve and to support the employment of the federated AI. Parts of the data, for example, the daily steps or daily hours of sleep, are collected in an automated way without user interaction. Other parts, the questionnaires, we ask the input directly from the user in predefined time intervals. Here you can see in the dashboard forms to collect the data related to nutrition, then the questionnaire section, those which are open for reply, and finally the activity and the sleep data already collected for a certain date. Sleep data include the total duration of sleep, as well as the sleep phases, deep sleep, light sleep, and REM sleep, and the awake time. So this is what we collect here. Now we go back, the activity data for a certain day. Again, include the number of active calories, the number of steps taken, and the total length of distance covered. Active calories as opposed to total calories, because the total calories is passive plus active for a given date. Activity and sleep data in the context of the app can be also presented aggregated in a weekly view. Steps and sleep per day, as well as in a monthly view. Steps and sleep per week. In the example here, it was created a couple of weeks ago. We have the week of 13, 19 February, or alternatively the month of February as a whole. Activity and sleep data, as we explained, are collected on a daily basis passively, as opposed to the data collected actively via questionnaires, which we will show next. So we will go back to the dashboard. and we will see questionnaires. Some of them come forward every week. This depends on how they have been defined by the clinical partners in the project, like the sleep quality questionnaire. Here I fill one example reply. There are other questionnaires which come forward every month, like the Hamilton Anxiety Depression Scale, which the user must fill in within a predefined time frame from when they received it and send it. Now this is also a quick demo. I start filling in this HUDS questionnaire. I want to show in this demo that I can navigate back to the dashboard at some point. As long as the time is not up, I can close the app and reopen it on the next day. I can go back to the HUDS questionnaire and continue with the reply from where I left off. Now, depending on the needs coming to the project from the technical partners, some questionnaires could come forward every 3 months or at the start and end of the trials period. Now, an open issue in general, what I wanted to give as a key takeaway to the audience with this kind of data capturing or so-called tracker apps, especially when it comes to data we ask to capture directly from the user, is the retention of the interaction over several weeks or months. Users, we expect them to, we believe that they could easily grow frustrated or bored of filling in the same questionnaire over and over. For this, we rely on 2 things, engaging user interface that we have designed with the help of experts, as well as the interest of the users to participate because they perceive the value of the research outcome. Development of the Faith mobile app is still ongoing. I showed there that the next steps we have now is the creation of the profile page and the calendar view. This was the last 2 frames of my video. And as I said before, this is what we call the first version, in the sense that the second version should also include all the federated AI module that will transfer knowledge coming from the collected intelligence back to the user of the mobile app itself. This was Stefanos Venios of Suite 5 Data Intelligence Solutions, which is a partner of the Faith project.
Thank you, Stefanos. I'm going to introduce Xenia next to present the work we're doing on the trials in the project.
Mm-hmm. Are you sharing, Gary, or?
I'll share my screen here now, yeah. 2 secs.
So, hello, everybody. Good afternoon. I'm Xenia Beltran from Universidad Politécnica de Madrid. Okay, I'm from LifeSTech in department in the Polytechnical University of Madrid, and we are leading the part of, together with the hospitals, okay, all the area of the trial. Next, please. Okay, so our approach in Faith, okay, goes, and the trial goes coupled with the technical developments that you have seen before and explained by Gary and by Stefanos. If we want to split a little bit our approach, okay, even technically, we can say that we have 3 phases. The first one was the requirements. The second one, as explained by Gary, the second one is what we call the alpha applications, okay, which is the application that you just saw from Stefanos. That's the current development and our current status right now, together, okay, with a backend for the point of care to support the trial. And this first phase of the application, okay, is the aim is to really allow the capturing of the data of the trial, as our study is prospective. So we are using the data for modeling, okay, that is gathered in the trial study. For this, we are creating this repository, as Gary said, that is a private cloud, okay, and is for sharing and doing the analytics. While we're doing the study here and we're developing the trial and capturing data, okay, our study will allow okay, to start with analytics and modeling and evolve this application to the next applications, which will be the final application in Faith, which is the federated application. It will rely on federated learning, and actually the approach, it will be taking directly data from the phones, okay, in a secure manner, okay, and be able to have the model to fly, okay, over the different points that provide data to the application and to the models as such. So next slide, please. As commented, we're working with prospective data. So our trial is a multi-center, prospective, and observational trial, let's say it that way. For this, we have done several things. Among those, okay, we are working with a statistical plan, and this statistical plan supports two things. One is the sample calculation, and for the sample, due to the COVID and to avoid issues, we have done two plans, plan A and B, to have a backup, okay? And the plan B, which is the last one we want to work, it provides the minimum sample that it has been fully calculated to generate the federated models. Our idea is, and we aim to reach, okay, the 300 patients, okay, through all the centers that are the 3 centers explained by Gary in Portugal, Madrid, and Ireland. In this sense, okay, as for the alpha stage and alpha application, okay, we're working with this private cloud. Everything is anonymized, and we're working not only with anonymous data for doing the modeling of the future federated application, but also we're using all the masking approaches needed, okay, not only for allowing privacy, but also avoid bias, okay, in all the generation of the models as such. So we're in, we have a circle because this is our current state, okay. We are processing, we are going through ethical committees. Most of the protocols have been approved in all the centers. Actually, our applications are almost also ready to be applied. So next, please. This is a picture that really illustrates our approach right now. So actually we have a backend, okay, with a web tool at the hospitals and points of care, which will support not only the alerts, okay, but also generate the agendas for the trials and that support the system in the applications of the patients, which you can see in the right-hand side of the slide, okay. It allows the CRF collection and clinical data collection also that is going to be used, as well as also collects all the patient-reported outcomes, okay, of all the questionnaires. We're using standardized and validated questionnaires, validated in all the countries. So actually, to have not only a standardized manner to compare data later, but also, okay, known that all these tools will avoid a part of the bias and have been fully tested in all the countries as such. So everything is supported by the data infrastructure, as commented in the cloud, that not only has the repositories that handle in a private manner all the data, but also it has the APIs that support the services that really enable secure transference from the applications to the cloud, and to the cloud, from the cloud to the application as such. And the data infrastructure that is in the application, as commented, okay, we mostly, as commented by Stefano, is in the background of the patient. So everything that goes with the models of sleeps and activity is not felt or really need to be fully tracked by the patient, but only we have the intervention regarding the questionnaires that need to be filled, and some of the nutrition issues or voice approach and data collection that we need from them. So next, please. This is a representation on how our trial goes. So actually we have the calendar that is driven by the protocol, and actually all this has been integrated in the Faith app as an agenda and actually using quite a very patient-oriented and user manner. In the back, okay, we have the Fitbit and everything, even data for the Fitbit has been pseudo-anonymized. So actually we ensure that the data that will go and is used, okay, is not even identify the patient at that point. and the data coming from the hospital, that it will be in the cloud. And then, okay, when we put it together, then we'll be doing the model. Next, please. As for our trial, I want to say that what we aim is to have this continuous monitoring of the daily activities in sleep, voice, activity as such, and nutrition. Those are our models. And actually, we are doing is that with the statistical plan, okay, we have put together the tools, okay, for doing the predictions or how these parameters, let's say that way, okay, can predict, okay, the depressive symptoms when we compare with the depression questionnaires, which we're using the HAM-D and the HATS as such. To this, we are doing this statistical processing, and we have generated already a data model. Our data model is FHIR-based, okay, and the data model is also what we are starting to initiate, to evolve, okay, for supporting the federated application in the next step. We also are working not only with the missing values, okay, our statistical plan also has all the sizing adjustments that we foreseen for having the plan A and B. And also, which is very important for us, have intermediate analysis that really allows us to build the federated application while we are going with the trial as such. Also to say, next please, that if we want to summarize at the end, what we can say is that what we are doing, what we want really is to bring the attention of the healthcare services and the point of care and people, that is cancer survivors as such, okay, when the depression markers show sign, okay, when we want to do it as early as possible, as soon as they start. For what? We really want to downward the trajectories of depression, okay? We really aim to identify the trends, okay, with the areas and models that we are building and how they can affect not only the depression, but the quality of life. And our how is the FAITH application, which is provided this Federated Artificial Intelligence post-cancer support, okay, that using the app provides provides an easy way and an easy tool to be used by cancer survivors, okay, to really have this depression early diagnosed in a predictive manner. So with this, okay, we think we have mostly summarized, okay, the project. Thanks, Gary and Stefanos, for all the previous presentations that support ours. Well, the floor is yours, Tom. So thank you. We go for questions.
Thanks, Xenia and Stefanos. I think we also have Philip here, who is the technical manager for the project.
Okay, I'll take it before if it's okay with anybody. Gary, Stefanos, Xenia, as ever, thank you all very much, and Philip, of course. We don't have any specific questions in the chat, but what I'd like to do is ask about, we're going to go in FAITH project, we're heading towards the clinical trials. And I'm asking this question to everybody involved at the event, but also those involved in the project we've seen beforehand. What are the main issues when it comes to clinical trial that you're experiencing, or what are the barriers that you're seeing at this moment of time? Because the more we can share knowledge and understanding, the better we can prepare going forward. So I'd like to just put that on the floor. Is there any advice there for us on how we can prepare better for our clinical trials?
Do you want me to get it?
Go ahead, Xenia. I can't hear you.
Do you want me to get it? To get the question? To answer?
Sure. Go ahead, Xenia.
Okay. I think there are several things, okay, that are barriers, okay, because right now, I mean, COVID has been for sure a big issue. Okay, we started the project and we mainly have worked during the last years, okay, with the COVID issue. So actually, people and cancer survivors that are which their health, okay, status is good. It's healthy. Let's say that way. They usually don't go to the medical appointments, so it's quite difficult sometimes to keep the follow-ups and and actually the contact. Okay, so actually the recruitment is hard, and I think it's an issue that also could be for many other areas or for any clinical trial as such. The good thing is that many of these clinical trials, and we have got an experience of how remote clinical trials are working. Actually, what we are supporting right now with all these devices is this part of these remote clinical trials. So we expect that also there is a higher adoption than before, okay, or than even when we started the project. The people have these applications to be used, okay, and to really connect in a remote manner, in a more trusted manner than before. But it's for sure that unethical committees are also, with the new regulation of the GDPR and privacy, are getting also much more strict. So actually all we want to present, and we have to present several times, the protocol to ensure that actually we are first fully patient oriented, second that we have all the APIs and GDPR regulation compliance, and third, that if we are doing things like, for example, for artificial intelligence, data transfer agreements agrees with confidentiality and privacy from all the partners for processing the data, and for data providers and for data processors as such. So I think altogether it puts some barrier, but I mean, we're happy to go through them and work with them, because it's part of the big experience that Fate is giving to all of us.
Thanks for that. I kind of get it, but my worry too going forward is that we lose patients in the process. I don't mean from mortality reasons, but because they drop out. I think that's the word we can use. Victoria, would you mind coming in here? Victor, what are your thoughts on this? How not to lose patients? Do you have any thoughts on that one there?
Hi, Tom. Let me share my image. Can you hear me?
Yes, perfectly well.
Yeah. Well, I think that regarding this question in PERSIST, we faced some problems because we ran the clinical study right now for a year. So patients started to get a bit tired of wearing bracelets even in summer, so they wanted to go to the beach, and these kind of things that pose a burden for them, made them to start to think of leaving the study. So for us, this was a very hard time for clinical partners. They have to make a big effort to keep the follow-up with patients, phoning them, encouraging to keep working with us, and explaining them that their data was really important for the research. So in the end, and I think that this is a big work for clinical partners, and they make a big effort to keep these patients into our study. I think that we have to thank these clinical partners for keeping these patients in the study, because we face these kind of problems.
Yes, it's a constant worry, and someone's coming this way. What I'm worried about is that it's maybe it's just an idea. I throw it out there. Is there a way to incentivize patients to stay in the trial? Because clearly it's an effort to bring some patients in. I understand. Xenia was very clear how that happens, and if you lose them, it's almost repeating it. And if you had difficulty initially, then the more the drop out, the more the difficulty. So it's not like replace one-on-one. I think there's more effort to get more in second time around. So is there any way? I don't know. Maybe Antonio, you can come into this conversation too. Is there any way to incentivize people to stay in the trial? Is there something that can be done, or have you any knowledge or understanding how this was achieved? Antonio, could you come into this conversation? Is this possible?
Tom, I guess just Gary here. I think that's one of the things that Stefanos actually raised, is saying when we're going back to the users or the patients repeatedly with questionnaires and questions, it's trying to keep them engaged and trying to appeal to, I guess, to their good nature, that they're helping people going forward. I don't think we can give like monetary or material rewards, but it's appealing to the type of person that will actually get involved with these trials.
Let me try and ask, if we can't incentivize them, is there something like more visits to them, or more direct engagement, or like more weekly meetings, or something like that? Would this work? Because I have this fear that under assisting where we were because of the lockdowns and all this kind of difficulty we've gone through, that over this specific period of time, people will not be as enthusiastic of being involved, and therefore how do we make sure that we don't lose them? And that's one of worry. Antonius, welcome. I'm just curious, what happened in live chat? Do you have any incentivication method, or do you have any kind of way to keeping people in board on unit trials so we don't lose them? Have you any experience that way?
Well, one strategy that we try to follow is that, as we described in our presentation, our aim is that by day one, we include patients, and we keep following up with them in different activities that we try to involve them. The design of the application, the data collection studies, again, with feedback, etc. So this way we try to build trust with them, and we try to keep them engaged throughout the project, and even create a team, let's say, of patient experts that will be also ambassadors for bringing into our studies other people as well. And we also try to be engaged with patient associations. Patient associations play a key role into asking patients to be involved in different activities, even into research. So I think this is key to find people that could also act. I mean, we have the technology, but we also need a human factor to help us to drive the implementation of the research. Otherwise, technology on its own, it's difficult to be implemented. We need also to have a human factor as an intermediary to deliver the technology.
Okay. Thanks everybody for having that kind of conversation. Pretty good. Now, in terms of time, we're doing our best we can to keep to the time. We're going to head into another short little tea coffee break. I call it tea coffee break, but the whole idea is that you drop out for 10 minutes and then check any emails, whatever you want to do, and then we come back on again. So if we can just go to the next session. Sarita, can you please put up the next slide? And again, thanks you all for this conversation. Gary, Stefanos.
So shall I show the poll for Faith, or shall we move to?
Oh, do we have? Absolutely, please do.
Okay. Let me just share it. Okay.
So here we have the poll. Do you see faith type trackers as something that you would use? And then we have 5 options down here. I have never used a tracker app and I would not use one is one. Another answer is I have never used a tracker app, but could see myself using the Faith app. Please, while I'm reading, vote as you see appropriate. I use a tracker only for exercise tracking, but would not go beyond that. The 4th one is that I use a tracker only for exercise tracking, but would expand to capture more than exercise to use the app. And the final ones, I regularly use a tracker and more than experience that and would use the Faith app. So these are the 5 suggestions towards you. Please give us some feedback. The more feedback we get, the more we will help us with it, our track. You know the methodology. The link is there on the app. You can just go into. So I did this for everybody else. And then we've got to move it to, you can also use the code there on the YouTube. So you've got some options. We keep it open for a little while and then we go to the second question. Oh, sorry, my questionnaire doesn't work. Doesn't refresh.
No, I'm the same. I guess this question really was going with the premise that there would have been a lot of patients involved in the event today, and it was trying to gauge whether people are inclined to use this for I guess, exercise only, or go beyond and start using these type of trackers for health?
Okay. All right. I think we're having trouble with the tracker at the poll questions. So I suggest rather than do it now, we'll go take a look at the second question, see what it was. But I don't think
I think we need to use different code for the Mentimeter. I mean, this one is a new code.
Okay.
Can you share the code in the chat, please, Zoraida?
Yeah, I think it's shown in the slide.
Yes.
If you
okay, now it works. Now it works.
If you go to menti.com and then check, I will change the code in the chat. Yes.
Yeah, exactly.
If you go to menti.com and use the code that is shown in the slide, that also should work. I will copy the link.
Yes, please. Okay, give it a little bit longer as we're getting in there now. And
it's interesting to see that a lot of people are already collecting health data on their mobile phone. But I guess I always look at these questions and what we're doing in the projects, and then look at I guess, as an audience, we are people that will already be using new technologies. Whereas if you go into the general population, if I start talking to my friends outside of these projects, they're not so inclined. There's a big trust issue that needs to be overcome with regards to tracking still.
yes, I think this part of the discussion we had this morning, Gary, is trusting the algorithms and so forth on that, and that's something we'll have to overcome in time. But that's it.
And I guess for the projects that are going to the hospitals, it goes beyond the user trust. It's also the clinicians that are getting the information back from the algorithms that the clinicians also trust. So we're supporting them. I'll be quiet now.
Yeah, no, appreciate it. We're running over time at the moment of time, so I'm suggesting we just stop the session. My thanks to everybody involved, including those who participated in the general discussion and those who were able to do the chat. We're going to go to just see this afternoon session. What we will do now, we're running.